I think Xiaochen, we have enough people, so I can just introduce you and you can.
Okay, thank you.
Hi everyone. Welcome to 140th Stanford MedAI Group Exchange session. This week we have Xiaochen Wang from the Pennsylvania State University, and he is going to talk about his work on federated knowledge injection into medical foundation models. Xiaochen is a PhD candidate in the College of Information Science and Technology at the Pennsylvania State University. His recent work focuses on advancing multimodal healthcare foundation models through techniques such as multimodal pre-training, federated learning, and parameter-efficient fine-tuning. His research has been recognized at top-tier AI conferences, including ACL, EMNLP, NAA, CL, NeurIPS, and KDT. Xiaochen, thank you very much for joining us today. Before we start, do you have any preference on how you would like to take questions? Can we interrupt you in the middle, or do you have designated breaks in your talk?
Yeah, feel free to interrupt me once you have any question.
Okay. So everyone, let's try to make this session as interactive as possible. And without further ado, let me hand it over to Xiaochen.
Okay, thank you. Thanks for giving me the opportunity to introduce our recent work on the federated knowledge injection into medical foundation model. So I'm a PhD student at Penn State University, and these research works are some result of the collaboration with our collaborator at Georgia State University and Sony AI. So here are our today's agenda. So basically in this talk, I would like to introduce a new task that we propose, which is a federated medical knowledge injection to the medical foundation model. So in the introduction, you will learn about a benchmark, which is the benchmark that we submitted and accepted by Europe's 2024 dataset and benchmark track. And also based on the work on the benchmark, we first take a further step by developing a new novel method called FedKIM, which try to leverage the parameter-efficient fine-tuning technology to better let the model comprehend the injected knowledge. Yeah, so I would like to start from the introduction of the research background. So in recent years, healthcare or the AI for healthcare has been very popular or attractive to both industry and academia. So people start to explore different applications regarding the healthcare using some data-driven way. For instance, we have different applications like disease diagnosis, prediction, or some drug discovery, development, or reversely, some types of adverse drug reaction prediction, something like that. And also we have the genomic data analysis or even reanimation prediction, which is very necessary for some companies like insurance companies. So we can see that we have a lot of healthcare applications in current stage, and these applications are supported by different types of healthcare data. So in recent years, especially in recent 5 years, we observe a significantly increasing of the healthcare data. And these data are belonging to different types, like we have electronic health record data, which can be regarded as some combination of different modalities data. We also have the pharmacy and the prescription data. We have the health insurance claims. We have other types of clinical reports like discharge summary. And also we have the conventional medical data, which is medical imaging data. So we can say that nowadays, researchers inclined to utilize a specific type of healthcare data to develop their desired healthcare applications. But nowadays, as we have more and more powerful model, some researchers start to be curious whether it is possible to just develop a single model or a unified model that is capable of handling different types of data along with different types of tasks. So here we have the first question: is it possible to develop a comprehensive model that is capable of handling diverse types of healthcare data for a wide spectrum of applications? The answer is yes, and the answer given by the researchers is called the concept of healthcare foundation models. So basically, in a paper published at Nature in about 2 years ago, researchers started to develop the concept of healthcare foundation model. So basically, they describe two major characteristics of the healthcare foundation model. The first one is that the model is expected to tackle many types of input data in different modalities. So conventionally, we have some large language model which can only tackle the text data, but as forecasted by the researchers, we need to tackle different types of data like audio, medical image, electronic health record, ECG signals, etc., to allow the model to be very powerful to tackle different scenarios. So the second characteristics is that the model should be used in different types of applications like chat or active note taking or some types of diagnosis, etc. So it basically describes these two factors, these two aspects. The first aspect is the modality aspect. The second aspect is the task aspect. So it is just a position paper without any experiments, realization, or implementation. But in recent years, researchers start to implement this idea by their own research work. For instance, the developer of MedLlama, which is a very powerful medical language model, they developed their model that let the model handle different types of tasks in addition to question answering. So the proposed model can tackle tasks like text classification, task summarization, or even name entity recognition, which is a more fine-grained task. And also researchers start to do the exploration in the aspect of modality as well. For instance, researchers start to develop multimodal or vision language models like MedFlamingo to let the model make sense out of the medical image as well. So the model can take the medical image and the text description as input and to tackle some more complex tasks like the visual question answering. However, even though we have observed some success in this domain, there are still some limitations of the healthcare foundation models nowadays. So given this table, you can say that there are two major problems. The first one is that most of the healthcare or medical foundation model only focus on a very narrow spectrum of the modalities. So most of the models can only tackle the text input, while the others can also tackle the image input. However, we have a lot of modalities, as what I just mentioned, in the healthcare domain, like the ECG signal. So current foundation models, they do not have sufficient capability to tackle these kind of modalities. And also, you can say that most of the healthcare foundation model, they only focus on the specific tasks like question answering or visual question answering. Maybe some outliers can also handle some fine-grained tasks in the domain of NLP, but we can say as we also have some other tasks like diagnosis or some readmission predictions, we can say that the task is still the tasks that can be handled by the current healthcare foundation model is still insufficient. Yeah, so you can see that most of the existing foundation models have relatively limited capabilities with respect to both modality and tasks. And this drawback or limitation should be largely attributed to a nature in our current utilization of the healthcare data. So according to a report, most of the healthcare data is still unused or underutilized by the researchers or the developer in the industry. So it is primarily due to the reason of the privacy issue, due to the several regulation or laws or policy regarding the healthcare data protection. So in the United States, we have HIPAA prohibiting the free sharing of the sensitive healthcare data, and also in other regions all over the world, like EU, Australia, China, people usually have their corresponding laws to prohibiting the free sharing of this kind of sensitive data. So it basically means that we cannot use sufficient data to develop a model that can tackle as many modalities as possible and also tackle as many tasks as possible. So yeah, so data becomes a very essential problem for us to tackle. So given that most of the data cannot be freely shared or distributed, so it comes to a research question, which is that how can we build a foundation model based on that? So in the general pipeline, if we want to build a foundation model, we can just gather a large amount of general data, and then we just use some task-specific data set for the fine-tuning. And finally, we have the final delivery, which is something like a checkpoint that can be used to directly tackle different types of tasks. But here we do not have enough centralized medical data, which means that we cannot access the data and gather data for training. So it prohibits the general pipeline of developing the foundation model and prohibits us to just transfer the experience in the general domain. So it proposes a research question here, which is, can we just build a multimodal and multitask medical foundation model in a relatively collaborative and distributed approach? If we can just use a large amount of unused distributed data scattered in different hospital, clinics, and research institutions, and to jointly utilize this kind of private data to train a foundation model, it can be significantly helpful. So federated learning becomes a very useful approach to achieve this goal. So federated learning aims to collaboratively train machine learning methods while keeping the data decentralized. So in the paradigm of the federated learning, we have some private data stored in individual hospital. The data cannot be freely shared. However, the hospital is capable of training their own model using their own data. So we have different models trained with the data scattered in different hospitals. So instead of just sharing the sensitive data, what we can do here is to share the model checkpoint, to upload the model checkpoint to the server end, and then perform the aggregations of these model checkpoints. Basically, without the sharing of data, we produce a model that benefits from the distributed private data. And after the aggregation, what we can do here is to download the model back to the local end, which means that each hospital, even though they do not need to share the data, they can still benefit from the data stored in other hospitals through this federated process. So it is a key idea of the federated learning in the clinical scenario. And it is built upon the assumption that each participant is treated identically with respect to data, model, and others, which means that all the hospital will participate in this process and benefit from this process, which ensure a very good utilization of all the scattered data. So impressed by this kind of federated approach, we're thinking about the possibility of developing the multimodal healthcare foundation model using the federated learning pattern. Therefore, we propose our new task, which is a federated medical knowledge injection into a medical foundation models. So the idea is very clear. So here we have a centralized healthcare foundation model, which can only tackle a relatively narrow range of modalities and a narrow range of the tasks. So what we are trying to solve here is that we are looking forward to see if it is possible to just utilize the scattered data to benefit the centralized medical foundation model to let the model becomes capable of tackling more modalities and tasks. So that's a new task. It seems to be relatively novel, and we still have no solutions before our work on this area. So how can we develop a relatively preliminary but feasible solution to this problem? That becomes a good question. So what we do here is that we perform the training in the local end. So remember that our assumption is that most of the data are stored in each client, something like hospital, clinics, research institution, without any possibility of sharing. So what we can do here is just to make use of this private data to train a relatively good local model. So to ensure that the local model can benefit from the data in different modalities and the data for different tasks, we design this kind of multitasking and multimodal local model. So we can say for different modalities, it has different modality-specific encoders, and also for different tasks, we have different task-specific decoders. So it ensures that given any types of the training data, we can perform the local training to let us obtain a relatively good encoder and decoder through this optimization. So here we have, for each task, we have a task-specific loss function, which means that we can do the optimization on all the encoders and all the decoders. And also we can say that the target of the optimization is obtained through the encoding and the decoding with a modality-specific encoder and a task-specific decoder. So it is not a very sophisticated design, but it allows us to benefit from the local private data with different modalities and different tasks. So in this step, by using the local model, the multitasking multimodal model here, we can extract the information or the knowledge contained in the scattered private data.
Xiaochen, can I ask a question here?
Yeah, go ahead.
So I understand you have task-specific decoders and modality-specific encoders, but your figure, it makes me think that there is kind of a common representation somewhere. So is there any part of the model which is shared between different modalities?
Yeah, that's a good question. So basically, here, you can say that in this table, you can see that one of our training tasks, which is a mortality prediction, leverages different types of modalities like vital signs, live events, input and output. So they can be regarded as different types of time series. So what we are doing here is that after obtaining the representation for each modality, we just do the concatenation to generate the unified representations of all the multimodal data, and then utilize this concatenated representation to do the corresponding task. Does that make sense?
Oh, yes, thank you.
Mm-hmm.
So Shishin, I have kind of follow-up question. So
Mm-hmm.
you selected the task based on the fact that they are independent, or you selected the task based on the fact that they have some dependence?
Yeah, that's a good question. So basically, we consider both of the factors. So you can say that two tasks here, the COVID detection and
Yeah, and the
lung
lung
opacity.
opacity, they are highly dependent, right? While
Yeah,
the
yeah,
mortality
exactly.
and probably ECG, I don't know if they are dependent.
Yeah, they're dependent. So basically, they're using the same encoder, which is the image encoder. So which means that they will be jointly optimized during this multitasking
Yeah,
optimization.
that is my question, right? When we consider multitasking, our hypothesis is that there is some dependence on the task, right?
Mm,
They're not
yeah.
completely independent, but based on your task selection, it seems that you particularly selected some tasks that they are dependent, while you particularly selected some tasks that they are not dependent. I don't know if it is just a choice or the data
Uh,
that you have.
yeah, it can be regarded as a choice because
Okay.
yeah, we would like to see if so of course we can just select the COVID detection and the lung opacity detection individually. So we can just select them without any overlap. So we can just cover one image related task in this table. It is absolutely feasible, right? But what we would like to see is that is that possible for us to obtain a better performance if we just cover the task with shared modality? Which means that we can simultaneously optimize the encoder with two tasks instead of one. Does that make sense? So that's why we choose to use some overlapping tasks for doing the optimization, because it can allow us to jointly optimize the encoder for the image.
And when you are training, actually, you are doing end-to-end, like you are backpropagating also to the encoder.
Yeah, exactly.
Okay. Okay, got it.
And I
Yeah.
think we have a related question in the chat. Is there any patient linkage between tasks? So I'm assuming it's about the data set. Do you have like same patients within like different tasks?
Yeah, that's a good question. So actually, we are using the data type from different sources. So I think that we do not have the shared patient
Okay.
yeah, in the training, because these data sets are highly from the absolutely different sources. So we do not have any shared patients in this stage.
Okay. Thank you.
I have a question about how does the architecture look like?
You mean the architecture?
Yeah, you have encode different encoder for different modalities,
Mm-hmm.
and you have some representation in the middle.
Mm-hmm.
how the representation architecture look like?
Yeah, that's a good question. So basically, I think the architecture is very simple because for each modality we have different encoders, right? So after that we have different types of representation. So what we are doing here is that we just do the aggregation of the representation generated by each modality-specific encoder, such that we have a unified representation for all types of modalities. And what we are doing here is that for different tasks, we just pass the representation to the corresponding decoder, which can be regarded as some types of head for each specific task. So basically, if we just take a look at one task like the image classification task, you can say that if we just train on the, for instance, COVID-19 detection task, what we're doing here is that we just pass the image into the encoder and then have the representation and pass the representation to the corresponding head, which can be regarded as some types of MLP. So you can say it's a relatively simple design. And also for other types of um, modalities like the signals, we can say that signal will be passed into a specific encoder, which is a CNN, and then the CNN will generate a representation, and then the representation will be sent to the corresponding head, which is a head for the ECG abnormal detection head. Does that make sense? So it's very simple.
Okay, I got it. So how the tasks can benefit from each other?
Yeah, that's a good question. So you can say that's for the different tasks like lung opacity detection and COVID-19 detection, we use different decoders, right? So each task has their own specific decoders. But actually here we share the same encoder, which means that in the training with the long opacity detection datasets, we optimize the encoder. And also in the training of the COVID-19 detection task, we also optimize the image encoder. So which means that we can jointly train the encoder with two tasks related to the image. Does that make sense?
Actually, I'm more interested about modalities. How your image benefit from your lab test?
Yeah, that's a good question. Actually, they're relatively independent from each other. So that's why we just choose to cover this range of tasks because you can see that we have some case that we let the model to benefit from some joint modalities, and also we have some case that we have some modalities that do not have any relation at all. So yeah, does that make sense
And
to you?
you try mimic dataset, which covers images and lab test or all kind of clinical data, and they're linked through patient ID.
You mean do we have some data that contains all these types of modalities and can be linked with a patient ID, right?
The first data set to my mind is mimic data set.
Yeah, exactly. So for Mimic, we can jointly have all this kind of information um, connected by the patient ID. But one thing that I would like to mention is that even though we have the patient ID, we cannot ensure very good alignment between the cross-modal data for the same patient because for instance, for the radiological image in the mimic data sets, we has its corresponding clinical report, which is absolutely correspond to the radiological image itself. But for other types of modalities, like the discharge summary in the ICU, it may not be relevant to the same patient, the radiological image of the same patient. Does that make sense? So the alignment is not very strong, even though we have the same patient ID.
Yeah, I don't want to make this too long, so you go ahead, and we may have a private discussion about this. Thank you.
Okay, thank you.
One quick question I have is, so like say you have the encoding from the ECG signal, and then you have the representation. So the decoder for the lung opacity detection, that does it mean it doesn't see the representation from the signals at all? It only sees the representation like from the images?
Yeah, exactly.
Okay. Okay. Yeah. Okay. Thank you.
I think we don't have any more questions right now, so we can probably move forward.
Okay. Let's move forward. So in this step, we can say that we are trying to optimize a local model by using the multitasking multimodal private data, and it allows us to obtain a good checkpoint, which benefits from the private data. And another follow-up question is that how can we just make use of this good local model to benefit our centralized medical foundation model? So here we are trying to utilize a general federated learning paradigm, which means that we're doing something like aggregating the checkpoints trained on different pieces of private data stored in different clients. So here for each client, the D1, DN, we have the corresponding local model trained with their own private data. And then we utilize the conventional federated learning approach, like Fed average, to aggregate their parameter. Like for the model on the client 1, we have a piece of parameter, which can be denoted as P1. And then for the model on the client N, we have the parameter of this model, which can be denoted as Pn. Then what we can do is just to do the average of all the parameters to generate a global model that's partially benefited from all this kind of distributed private data. So it is a general federated learning pattern. And how can we benefit the centralized medical foundation model with this aggregated model checkpoint? So what we are doing here is just to plug the encoder that we obtained through the aggregation to the healthcare foundation model. So if you are familiar with some vision language model like Lava or LavaMed, you may know that they are utilizing the very similar approaches to benefit the multimodal foundation model. So basically what we're doing here is that we make use of a very small amount of public data to further fine-tune the encoder and to let the centralized foundation model make sense out of the representation generated by the encoder. For instance, for the public data, we have something like, for instance, the image classification task. We can have a prompt, which is, given the image, please judge whether it has tumor. So we can have a representation of this prompt, and also we can have the image itself, and the image will be passed into the encoder that we obtained from the federated training, and then we can have the representation of the image as well. And then we do the concatenation of the image and the prompt representation and input it to the medical foundation model, which is frozen here. So you can see in this step, all the parameters except the encoders are fixed. So we just want to further tune the encoder to let the large language model understand what the encoder output is. Yeah, so any questions so far? I know it's somewhat abstract, especially to those that are not familiar with federated learning.
One question I have is that again, it's probably just a depiction that when you have like one representation block, it makes me think that both the image and the prompt, they are being embedded into the same space,
Exactly.
right? But then if you freeze one of them and fine tune the other one, then potentially they are being embedded into two different spaces. Would that be a problem?
So basically, I think originally they're in different spaces because the encoder is produced by the federated learning. And for the large language model, it originally have its own semantic space obtained through the pre-training, right? So what we are doing here is that we jointly train this whole pipeline to just fine-tune the parameters in the encoder. And let the encoder be capable of producing some information that can be understood by the large language model. So here we are not doing something like split the semantic space. Instead, we are trying to unify the semantic space of the encoder and the embedding layers of the large language model. Does that make sense?
So there is the embedding layer of the prompt that's being fine-tuned as well. It's just
No.
an encoder. No.
Yeah, just the encoder. So yeah, I know you may have some curiosity on this design, but if you take a look at the paper of the LlamaMed, so they do something very similar to that. So they just want to, in the first stage of their pre-training, they try to establish the alignment between the novel modality data and the original semantic space of the learning model. Yeah.
So would that alignment be preserved after your fine-tuning or no?
Yeah, it can be observed because the training is quite stable. And also we can say in our following up experiment results, the healthcare foundation model previously cannot tackle any types of image-related task. It can become capable of understand some types of image after this kind of fine-tuning.
Okay, thank you. And I think we have one more question. Do you sum all the losses together? I think they're talking about the losses that you were describing in, I think, some of your previous slides. There were the task losses separately, I guess. So do you sum them all together?
Yeah, so in this stage, in the local training, we do the summation of all the training loss to obtain a relatively good local model. Yeah, so, but I would like to point out is that we are in a different stage. So in this stage, we are doing the local training. We are trying to obtain a relatively good local checkpoint. And here we are trying to optimize the encoder based on the healthcare foundation model. So here the encoder checkpoint is uploaded from the local part, which means that it is independent from the local training. So here we just do the generative training as what we are doing for your multimodal language model. Does that make sense? Yeah.
Thank you.
Yeah, so here you can see that we are trying to parameterize the knowledge stored in the scattered private data and to just plug or inject this knowledge-rich encoder into the healthcare or medical foundation model. And through the usage of some small amount of public data, we're trying to let the centralized healthcare foundation model make sense out of what this uploaded encoder generated. And yeah, so stick to the conventional federated learning pattern. After the fine-tuning, the encoder will be passed back to the global model and distributed to different clients, which means that the client can also obtain a refined version of the encoder as well. Okay, if there's no more question, let's move forward. So based on this design, we propose our benchmark and platform, which is called FEDMEKI. So it contains about 100,000 of medical data spanning 8 tasks and 7 modalities, and we also utilize 4 metrics for the evaluation. So let's take a look at some of the experiment results here. So as what I just mentioned, the original model, the MedLM2, they cannot handle any types of tasks or modalities. So for tasks like the image-related task, originally it cannot handle it because it cannot make sense of the image at all, right? But after our procedure, here we can see that if we combine our method with the fat average to generate the global model and inject it to the centralized foundation model, it becomes capable of doing this kind of task, even though it haven't seen the task at all. You may notice that it is a zero-shot evaluation. And remember that we only use the COVID-19 and lung opacity detection in our training. So you can see that for some unseen task, it can still obtain some types of decent performance. However, if you take a deeper look at this table, you may notice that for some more complex data sets or complex tasks, like the MedVQA, visual question answering, or the signal noise clarification, which is some question answering task based on the ECG signal, we can see the performance can be extremely low, right? So it basically means that just to utilize this kind of injection or plug method to boost the centralized healthcare foundation model is good, but insufficient to achieve a relatively good performance. So that proposes the demand of developing more adaptive methods to let the model better understand what the injected or plugged encoder is and how to comprehend the output generated by the encoders. Yep. So here we have our own answer, which is a methodology that we proposed, which is called FEDMEKI. So it tries to adaptively inject the federated parameterized knowledge into the medical foundation model through the usage of mixture of experts and the LoRa module. So in case that some of you are not very familiar with the parameter efficient fine-tuning or low-rank adaptation, which is LoRa here, I would like to introduce some preliminaries here. So originally, when people want to train a model or fine-tune a model, basically what we are doing is about the pre-trained weights. We are trying to obtain a changed gradient, which is denoted as delta W here, through the training. However, training on the pre-trained weights can be very heavy because we have a lot of parameters. So instead of just training the pre-trained weights, we can just simulate the change of the W by using a low rank matrix. So here we simulate the gradient descent or the change of the weights by using two low rank matrix as some types of adjunct module in addition to the original pre-trained weights, and to achieve a relatively good performance in terms of customizing the foundation model with some lightweight adaptation. And taking a further step, some researchers, they try to develop something called a mixture of experts, which means that they would like to organize different LoRa more dynamically. So here we use, so the researchers use multiple LoRa for the low rank adaptation. And also they have a gating mechanism to control the weight of each LoRa expert. And then for the final output will be something like a weighted summation of all the output generated by each individual LoRa module. So it can help the model to get a more flexible and dynamic adoption in terms of the new input data. So you can see that this method are developed in the general NLP domains, which means that the researchers only focus on the natural language and try to tackle some tasks like question answering. But in our case, the scenario becomes more complex. We have different modalities, we have different tasks, and we would like to find a way to let the model better understand the complex scenario and to do the adaptation more flexibly. So therefore, we propose our own solution, which is multimodal multitasking mixture of experts. So basically, what we are doing here is to inform the model of the modality, the combination of the modality and the task to let the model dynamically select the most suitable expert. So basically, here the input of this module is a modality description and a task description. And they are passed into the embedding layer of the large language model or the foundation model. And after that, we have two embeddings, and we just input these two embeddings into a transformer block and to obtain some attention weights for each individual LoRa expert. So it is some types of simulation of the real-world clinic experience. For instance, if you do not feel good and you go to the hospital, you go to the front desk and describe your symptom, describe what you would like to get, describe the task that the physician, the doctor need to undertake. The front desk will direct you to the correct or appropriate expert. For instance, if you just have some injury, then the front desk may direct you to the first expert, who is a physician. If you have some issue with your lung, then the front desk will direct you to appropriate expert, who might be a radiologist. So by jointly consider the modality and the task, we can achieve a very similar performance or similar consequence that we can determine which expert need to be selected based on the joint understanding of the modality and the task. And finally, all the output of different experts will be weighted, will be calculated with a weighted summation, which means that we jointly consider all the output of all the LoRa experts, but with a weighted consideration based on the modality and the task. So, any questions so far?
So, but there is a limitation here, right? Like, because if you are now introducing a new task, you have to do the fine like tuning again, or you can
Oh,
use the weights from the previous task.
yeah, that's a very, very good question. Actually, that's something that we would like to tackle. So
Hmm.
remember that here we are using the task description and the modality description at the input, which means that it does not rely on some predefined categories, right? It is just about the natural language. So assume that we're having a new task, then we will have the description of the new task, right? It can also be generated to the embedding form by using the embedding layer of the large language model. So we can still obtain the weight for each expert. So it basically means that this module can be also transferred to some new tasks. Does that make sense?
Okay, but did you try to do the experiment, like how far the task can be from the original task, or is still?
Yeah, exactly. Yeah, we have some evaluation study to
Okay,
examine.
got it, got it.
Yeah.
I think we have one question in the chat as well. But, Dr. Liang, please let me know if this was for the last part of the talk, how much performance for one task can be gained from other tasks?
Sorry, could you please repeat the question?
How much performance for one task can be gained from other tasks?
Yeah, that's a good question. I think it is something that is not covered in this presentation, but if you take a look at our original paper of the FedKIM, you can still find that we have two sets of experiments. One is about the single task, which means that we just train the do the local training individually without any sharing across modality-specific encoder. And one setting is about the multitask setting, which means that we are trying to do the optimization by jointly consider different tasks sharing the same modality encoder. Yeah,
Okay, thank you very much.
I cannot recall clearly where the table is. Maybe it is also in the benchmark paper, but you can check. Yeah.
Okay, thank you very
Roughly
much.
give the numbers. Can you roughly give the numbers? 1% again, 2% again?
Sorry.
Can you give the numbers? Let's just say 1% again, 2% again.
I think the enhancement is relatively marginal, maybe just 1 or 2%. But considering that we are doing the experiment with some tasks that are not very difficult for the model. Remember that we have the task like the image prediction here. So it is not very difficult. So the original performance is something like already like more than 90%. So the enhancement, even though it is very marginal in terms of the value, it is still considerable. Yeah.
So which one gains the most? Which task gains the most from other tasks?
Yeah, that's a
Would
good
it
question.
would it be helpful if we include the links to the papers when we upload the
Okay.
video?
Yeah, can you send the paper and
Yes.
also point us to the tables?
Yeah, I will attach the link of the papers at the end of the presentation, and so we can have some discussion regarding the experiment
Thank you.
results.
Thank you, Xiaochen.
Yeah, so let's go back to this part. So I assume that we can proceed now. And yeah, so here is how we utilize this new method to achieve a relatively good performance by using the multitask multimodal mixture of experts plus LoRa experts. So basically, we stick to the same design that I introduced earlier. We are still trying to use a plugged-in encoder, which is obtained through the federated learning, and to generate the representation and allow the model to make sense out of the representation generated by the encoder. But the difference is that we leverage our mixture of expert design, which means that we allow the model to dynamically consider what the modality is and what the task is to dynamically select the appropriate expert to undertake this task. And finally, we perform the parameter efficient fine-tuning with all these modules, and we achieve some good results, which can be seen after my introduction of the experiment setting. So in the experiment, we still use the SIM backbone model, which is a multilingual medical language model. And remember that it can originally tackle the text merely. And also we integrate this backbone with two federated learning approaches, which is fed average and fed prongs. And also we perform the evaluation in two settings. The first setting is about fine-tuning, which means that we are trying to do the evaluation with the same side of the training and the test data sets. So we are remember that we are training the model with the following four tasks. And the fine-tuning means that we're doing the evaluation on the exact same side of tasks. And for the zero-shot evaluation setting, we are trying to train the model with the following four tasks, but instead we are trying to do the evaluation on the 8 new tasks that the model haven't seen during the training. So it can validate the transferring capability of our design to see whether the model can tackle some new tasks after this kind of adaptively training. And in terms of the modalities, we cover image signal, vital signals, vital signs, lab events, input, output, and text. And yeah, let's take a look at the experiment results. So for the original learning model, it cannot tackle any types of tasks since it is only a unimodal and a unit task foundation model. But after the injection, we can say that by using fed average, the FEDMEKI can achieve a relatively good performance. So as what I just mentioned, the performance can be relatively high because it is a relatively easy task, and also the model have seen the task already. But by using our mixture of expert design, in addition, we can achieve even higher performance, which demonstrates the effectiveness of the the mixture of expert design. And I would like to point out that for some task that is more tough for the model to solve, like the ECG abnormal detection and the mortality prediction, we can see a more obvious performance enhancement, which indicates that it is more necessary to adopt the mixture of experts to let the model understand the modalities that it will tackle and as well as the task that it will tackle, such that the model can be more adaptive to learn from this task and modality combination and to achieve a relatively good performance. And also we integrate our approach with two different federated learning backbone, and for each backbone you can observe some types of performance enhancement. You can see that the enhancements is more obvious, especially for the fed prongs approach in the federated learning. So it is about the multitasking fine-tuning evaluation, and you can say that the design utilizing the parameter efficient fine-tuning is very useful in terms of the performance boosting. And here we come to the zero-shot evaluation, which means that we are trying to see if the model is capable of handling some unseen task. So here we can find a black point, which means that originally the model cannot tackle any types of tasks. And after the usage of our federated learning approach, which is detailed in our benchmark paper, we can say that we achieve a relatively good performance. At least the model can somewhat tackle this problem, but the performance may be relatively suboptimal. And here what we are doing is that we integrate the original benchmark design with our novel proposed mixture of expert design, and you can see that we achieve a much higher performance in all the tasks. So it highlights the importance of considering designing a adaptive method to help the model better make sense out of the plugged in encoder. And yeah, the most interesting part is here, which is the observation study part. So as what we can say, we have two settings. The first setting is the fine-tuning, setting, we utilize a task of COVID-19 detection for the ablation study. And we can see different settings. Here, the FedKIM is a setting that we do not use any private data scattered in different clients, which means that we absolutely get rid of our federated learning architecture and just use a small amount of public data for the centralized fine-tuning. You can see the performance drops a lot compared with our FedKIM approach. So it basically means that if we just use a small amount of public data to perform the training, then the performance of the centralized model may not be as good as what we can see when we use the private data as well. So it highlights the importance of the federated learning. And here we have two settings. The setting denoted by T means that we merely utilize text description to guide, we merely use the task description to guide the selection of the expert. So remember, in the mixture of expert design, we are trying to integrate the combination of task description and modality description to guide the model to perform the expert selection, right? So here, we merely utilize a task description for the guidance. So you can say that we also have the setting denoted by M means that we only use a description of the modality to guide the selection of the experts. You can say that compared with FEDMEKI, which combines the information of task and the modality, the performance are relatively lower. So it basically means that it is good to consider the combination instead of each individual part of the complex clinical scenario, which means that we need to consider both task and modality that the model will handle, which can inform model of what the scenario is and allow the model to better understand what strategy it should take to get a better performance. And also, we have the setting of the zero shot, which means that we would like to examine each the effectiveness of each module in our design, and we choose a task here. You can say that's similar to our observation on the fine-tuning setting. We still observe a significant drop when we just use public data available in the centralized setting. So I think the most important observation is that the federated learning is very useful. It can help us to obtain some parameterized knowledge from this kind of distributed data, the private data distributed in different clients, and to benefit the centralized foundation model by enhance its performance. Yeah, so that's basically the main part of my presentation. So any questions regarding the experiment results?
Thank you very much, Xiaochen. Before we move on to questions, I'd like audience to give a virtual round of applause to our speaker. Thank you, Xiaochen, for this very interesting talk. And now the floor is open for questions. Please go ahead.
I had a question about the mixture of experts, and maybe I missed it. If you go back a few slides where the diagram is, here,
This one, I think.
and maybe the next one.
Next one, okay.
Yeah. So, for example, I did a very simple uh, federated learning study. So I have University 1, University 2, right? They both have some brain tumor images, and then I have a server. So typically, like so both universities are training the same model, and then they send their weights to the server where the weights are aggregated, right? And I use the same like Fed average at the server, and then send it back, send the updated weights back, and then repeat that loop. So here, maybe you said it and I missed it. I'm sorry about that, but uh, so you see that's what's missing for me is you have one foundation model, and
Yeah.
do you uh, like is the server yeah, like I'm missing like like connection to standard federated learning. If you can talk a little bit about like the server side, so and how you update the weights. Yeah.
Yeah, that's a very good question. So let's go back to this page regarding our benchmark work. Here Yeah, so I think this page is the best one to illustrate the
Okay.
paradigm. So basically, in the conventional federated learning, we do not have the part regarding injection and updates, and we also get rid of the medical foundation model, right?
Right.
What we're doing here is just to utilize some small model like CNN, LSTM, or even MLP to obtain some parameterized knowledge from the client, something like university or clinics, right? And then we have the local small models, and then we do the aggregation of the local models to obtain a relatively good global model, right? And then the difference is here in the original design of the federated learning, we just simply do the aggregation and then pass the checkpoint back to the local end, right? Yeah, so in our end, in addition to simply do that, we perform so-called injection. So we just plug our encoders. We just select our encoder and plug our encoder into the healthcare foundation model to allow the foundation model to have a more powerful encoder that benefit from the decentralized training. Yep, and we utilize a small amount of public data for fine-tuning, which is slightly different from the conventional federated learning setting, because in the conventional setting, we assume that all the data are private, they cannot be shared.
Right.
But yeah, as what we can see, we have some public data like Mimic3, Mimic4, or other types of public medical data, even though they only take a very small proportion of all the medical data that we can have, they are still accessible. So we assume that we have a small amount of public data on the server that supports our training or our alignment between the encoder and the healthcare foundation model. So so different from the conventional federated learning approach, what we are doing here is that we inject or plug the trained encoder to the healthcare foundation model, and then we optimize the encoder, and then we pass the encoder back to the aggregated global model. And after that, we are doing the same thing. We are trying to download the model to the client end, which can be universities, clinics, or other types of institutions. And then we do it iteratively, which follows the conventional design of the federated learning. Does that make sense?
Yep, makes sense. Thank you.
Xiaochen, then if we don't have any more questions, then I can probably end with what do you see as like the future direction of this work?
You mean my invention of the future direction of this work?
Yes. I mean, because medical foundation models were it's a fast evolving field. So do you think like the way medical foundation models are developing, this pipeline can keep up, or would you need to change significantly?
Personally, I think we can stick to this design because the problem is persist, right? So let's come back to the page regarding the problem. So even though techniques evolves in a very rapid speed, these problems still exist due to this kind of regulations. So currently we have a lot of healthcare foundation model, but most of them are developed centralized. So I think the current stage of the federated learning-based foundation model is still not very developed, and we think we still have a lot of work to do in this direction to get rid of this kind of data insufficiency problem by using some distributed private data. So yeah, I think it's possible to continue working on this direction by using this architecture or this framework. And also you can see that we just defined this task and we just developed relatively preliminary solution to this problem, but we fully believe that there are some other researchers that can stick to this direction and find a better solution to that. So yeah, I think it's my hope to what we can do regarding this task. Yeah, but simultaneously, in addition to that, we think that it is also possible to do some work regarding the knowledge part. So as what I'm illustrating here, so a promising foundation model should be equipped with the capability of handling different tasks and different modalities, but also it should be equipped with medical domain knowledge. So it is something that we didn't consider in these two works. So I hope that there is someone who can think about a way to integrate the medical domain knowledge into this kind of federated learning approach to let the model better learn from some explicit knowledge. So in this work, we just define the knowledge as some parameters stored in the encoders, right? So it can be regarded as some implicit knowledge, but it is also possible to just learn from some explicit knowledge from something like a knowledge base or publications or multimodal knowledge base. Yeah, so yeah, that's my personal points to what we can do in the future in this direction, but I do hope that we can do something regarding the healthcare foundation model.
Thank you very much, Xiaochen. So we are already over time. Thank you very much, everyone, for joining us. Yes, we will try to put the paper links. Xiaochen, if you can please share the paper links with us when we upload this talk. Thank you very much, everyone.